Okay, this video is the anatomy of the neck. One of the viewers asked me to go over this anatomy, so I'm going to go over it. I deal with this every day. I'm a neuroradiologist is one of the things that I do. And I read neck CTs, neck MRIs, and I do tons and tons of biopsies of the neck. So starting out with the midline sagittals, if you divided the patient straight down the middle, this is the nasopharynx, oropharynx, and laryngopharynx. So the nasopharynx is behind the nasal cavity. The oropharynx is behind the oral cavity. The laryngopharynx is behind the larynx. The larynx means the voice box, where the vocal cords are. Okay, so when you smell, when you breathe in through here, it'll go down through here. You breathe in through the mouth, it goes down through here. This is the uvula. Okay, this is the tongue. The back of the tongue is the base of the tongue. When you're talking about neck anatomy, you're going to talk about triangles. And the important thing to know is you need to know that the sternocleidomastoid muscle is the dividing line. It comes down at a diagonal, and it divides the neck into an anterior triangle and a posterior triangle. The name totally makes sense for the muscle. Sterno, because it attaches to the sternum. Cleido, because it attaches to the clavicle. Mastoid, because the upper part attaches to the mastoid bone of the skull. So then you've got the big anterior triangle and the posterior triangle. And then you'll subdivide these triangles into other anatomic regions. We'll go into that in just a moment. Okay? This little muscle with two muscle bellies is called the digastric. Okay? Di as in two, gastric as in bellies, two muscle bellies. Okay? The neck is kind of a big complex thing. You know, you can't just learn the neck all at once. It's not like 2 + 2 = 4. There's a whole bunch of little tiny areas. And the reason why we want to specify the name of all these different little areas, we call them spaces typically, or levels, is because we have to be able to precisely describe where there's an abnormal finding. I have to be able to precisely describe where is the abnormal lymph node so I know which one to biopsy. Okay, again, here's another look at the neck anatomy. Here's the sternocleidomastoid muscle going from the mastoid down to the clavicle and the sternum, and this dividing the neck into the anterior triangle and the posterior triangle. So here it is, it says posterior triangle. You can call this the carotid triangle. We just call it the carotid sheath. The muscles in front of the thyroid cartilage, we'll call it the muscular triangle. I don't actually use some of these words. Like I just call this the submental space. Mentum means chin, so submentum means below the chin. Submandibular means below the mandibular bone, okay? All right, so let's take a look at another image here. Okay, here are the triangles from a frontal view, coronal view. So right beneath the chin, submental. Beneath the submandibular gland located in here, this is submandibular space. So sub means below, and this is beneath the mandible. Okay. The muscular triangles, we don't care about them. We never use those terms. Here's the clavicle, and here's the sternum. So the sternocleidomastoid attaches to both. The clavicle has two distal heads relative to the skull, and there's the clavicular part and the sternal part. Okay, now here's sort of a approximate look at the lymph node categories. This is actually really important to me because I biopsy lymph nodes all the time. The vast majority of abnormal lymph nodes are going to be levels 2A. And the reason is those are closest to the mouth. So these drain right from the mouth. All the pathology comes into your mouth. The stuff you breathe, problems with your teeth, the stuff you eat. So this is the main area that gets big lymph nodes, is level 2A. And you'll also get a lot of big ones in 2B. And sometimes in these other adjacent areas. But most of the time when I'm talking about a lymph node biopsy, it's going to be a problem up and around the face and the mouth, level 2A or 2B, or it'll be a problem down in the chest, and that's going to be related to level 4, which is also called sternal supraclavicular, above the clavicle, supraclavicular. The internal jugular chain of lymph nodes has level 2s up here, okay, above the hyoid, level 3s above the cricoid, and then between the cricoid cartilage of the thyroid cartilage right below it and the trachea, upper trachea, the cricoid, you then have the clavicle, so that's going to be level 4s, okay? So that's the typical phone call I get. Ear, nose, and throat always call me and say, hey, can you biopsy a level 2 lymph node related to some pathology in the face? And then the body doctors, the hem-onc doctors call me and say, can you biopsy a supraclavicular lymph node, usually related to the patient having a lung cancer, or even sometimes an abdominal cancer spreads up the lymph node chain into the neck. So those are the typical biopsy phone calls. To biopsy something in these other parts of the neck is uncommon. I sometimes do those areas, but those are uncommon. Okay, one thing you want to know is you want to know about the digastric muscle, because this comes up a lot. It has an anterior belly up here and a posterior belly, okay? And here's the posterior belly. So di means two, gastric means bellies, two bellies, okay? That defines the top part of the level 2 lymph nodes. All right, now here is the lymph node. Here is the anatomical spaces in the suprahyoid neck. So suprahyoid means above the hyoid bone. And this is where we spend most of our time dealing with neck pathology. Here's where the tonsils are, and because it's around the pharynx, you can call it the pharyngeal mucosal space. Mucosal space is in contact with the outside world, okay, with your intestinal tube, the tract from your pharynx to your esophagus, to your small bowel and large bowel. That's your mucosal surface. The muscles for chewing are called the masticator muscles. The masseter on the outside, the pterygoids on the inside of the mandible. This is the ramus of the mandible, the part that comes up like where your sideburns are. Okay, the parotid is the parotid gland. It's a salivary gland. Get a lot of masses in there. I often do biopsies of those. Sternocleidomastoid muscles right in here. Carotid sheath is going to be the internal jugular vein medially. Internal jugular vein laterally, the internal carotid artery medially. Paraspinal muscles are back here. Right in front of the vertebra is going to be the prevertebral space, and that little space right here is going to be the retropharyngeal space. Okay. These right here is just color coding of the same stuff we talked about. Masticator space, masseter muscle, pterygoid muscle for chewing, parotid space, the salivary gland, carotid space. We call it the carotid sheath, internal jugular vein, internal carotid artery. The vagus nerve runs right through there as well. Prevertebral space right here in front of the vertebra, retropharyngeal space behind the pharynx. Okay, tonsil is going to be just lateral to the pharynx, to the oral pharynx. Okay. Now here we're going to start showing you some pathology. Pathology means diseases. So this is the epiglottis. Normally it should be real tiny, smaller than a pinky, but when it's big like a thumb, that means it's inflamed. And it's dangerous because it's right on top of the airway. It can close off your windpipe, your larynx, your vocal cords, and it can kill the patient. Sometimes the patient needs an emergency tracheostomy. They got to admit this patient, put them on IV antibiotics, and hopefully the airway will stay open. Okay, here's a necrotic mass in the superficial lobe of the parotid anteriorly. So ENT will call me up and say, can you biopsy this? I'll say, yes, of course. And I'll just stick a needle into it right there. Okay, you know, cystic mass in the parotid could be cancer. It's necrotic mass. Could be cancer. Could be a pleomorphic adenoma. Could be a Warthin's tumor. Those are typical things that I deal with all the time. Okay, now here's a tonsillar abscess. Okay. And the tonsillar abscess right here, ENT will drain this from inside. So this is an ENT case. They don't ever ask me to needle them from the outside. So these, you know, if they extend into the retropharyngeal space, you can also compromise the airway. So that patient will be pretty sick. Okay, here is just the area's level. So here is a 1B, meaning a submandibular lymph node. Here's a 2A, upper jugular chain in front of the jugular vein. If it's still it can be behind the jugular vein if it's touching it and still be a 2A, but if it's not touching it and behind it, but in front of the back of the sternocleidomastoid, then it's a 2B level lymph node. Behind the sternocleidomastoid, it's a level 5 lymph node. And again, the reason why, this is the sternocleidomastoid muscle with the asterisk. The reason why we classify all these spaces is we constantly get big lymph nodes in all these different spaces, and we have to be able to precisely communicate. I'll be on the phone with ENT to say, can you biopsy level 2A? Can you biopsy level 2B? Can you biopsy level 5? Can you biopsy level 1B submandibular? Can you biopsy, you know, a 1A, a submental? That's a typical conversation. Okay, here's necrotic lymph nodes, meaning there's necrotic dead tissue. Could be an abscess, but you see them bilateral, you start thinking about it. Metastatic squamous cell will be the most common thing, like a cancer on the base of the tongue, metastasizing to both sides of the neck in the level 2A lymph nodes. You can get cystic necrotic lymph nodes from other things, like from, let's say, thyroid cancer metastases, but squamous cell carcinoma mets, this would be the most common thing to have this appearance. Okay, here are some enlarged lymph nodes that are solid. When I see an enlarged solid lymph node, now I start thinking about lymphoma. Okay, that's characteristic appearance of a lymphoma. So this would be a 2A contacting the carotid, the jugular vein. This would be a 2B. It's still in front of the back wall of the sternocleidomastoid, but it's not touching the jugular vein. This is behind the sternocleidomastoid, so this is a normal sized lymph node. That would be a 5A. Okay, that's just how we classify all the lymph nodes. Here's, of course, the mandible. Here is the tongue right here, okay? And here's the oropharynx. Here's the carotid sheath. Here's the submandibular gland. Here's the platysmus muscle that you tighten up to shave, to tighten up your skin so you can shave. Okay, here's an enlarged lymph node. You can see this long axis is 3.58 centimeter, 3.6 centimeter. So by all criteria, that's too big. You get 1.5 centimeter criteria for the uppermost jugular chain lymph node, jugular digastrics, and for the submandibular lymph nodes, but anything 3.6 centimeters is way too big. So that's, the big size means it's potentially metastatic cancer, so I got to biopsy it. Okay, here's a normal thyroid, right lobe of thyroid, left lobe of thyroid, thyroid isthmus, the midline communicator, and we subdivided further. There's a nodule. This would be right thyroid upper pole, right thyroid middle pole, right thyroid lower pole. This would be left thyroid middle and lower pole, bigger nodule here. And so then we make criteria whether or not to biopsy based on how abnormal the shape is, both the size and the shape. So this one is looking like about 3 centimeters, so I would biopsy that no matter what the morphology. But this one over here being only about 1 centimeter, if it had low risk morphology, I wouldn't biopsy until it got bigger, until it got like 1.5 centimeters. We have all these criteria based on risk of cancer, whether or not we biopsy. Now here's some eye infections. Here's an eye infection on this patient over here, and it's localized just to the skin on the side of the eye. So that's a periorbital cellulitis. It does not go deep into the orbit. There's the ocular lens normal. Here's a cataract surgery replacement. The fat in the orbit is all normal, meaning low in density. This is a CAT scan. These are the external ocular muscles. Again, this is the orbital septum. There's nothing abnormal posterior to it, so it's a preseptal cellulitis. On this other patient here, this other patient's not as fortunate. They've got inflammation deep to the orbital septum. There's bilateral cataract surgeries. So this is a post-septal cellulitis, higher risk for blindness. This patient with the preseptal cellulitis, you can treat him with outpatient with oral antibiotics probably. This patient with post-septal cellulitis, perhaps from an ethmoid sinusitis spreading laterally into the orbit, this person's going to need IV antibiotics, be admitted to the hospital. You can see the mass effect pushing the ocular globe anteriorly. So he's got exophthalmosis, okay, proptosis, and that's worrisome. Okay, this guy's at risk for blindness. He needs to be admitted, IV antibiotics, get an ophthalmology consult. Okay. Okay, now we're going to do a little bit of vascular anatomy here. This is the internal carotid artery going up to the brain, internal jugular vein. The naming of the jugular vein components is relative to the sternocleidomastoid muscle because it's deep to the sternocleidomastoid muscle. It's inside the sternocleidomastoid muscle. It's called internal jugular vein. This vein right here that's on the outer surface outside the sternocleidomastoid muscle, this will be called the external jugular vein. And then there'll be one, sometimes you'll see one anteriorly, and that's the anterior jugular vein. Okay. This vein right here is called brachiocephalic because it drains blood from the arm, brachial, and from the brain, cephalic. Okay. This vein is located beneath the clavicle, so it's called sub-beneath clavicle. Okay. So most of these names actually make a lot of sense. All right. Here is the common carotid artery in the neck. It bifurcates into the internal carotid arteries and go up to the brain inside the skull. Here's the external carotid right here with the branches. All right. And the way I remember is just my thumb. My thumb is the internal carotid artery going up to the brain. External carotid is my fingers because they go to the face. And the way I remember is I just make mnemonics. So SELFO-PSM. S for superior thyroid, that goes down to the thyroid. A for ascending pharyngeal, goes up. L for lingual. F for facial. PSM, posterior auricular, S for superficial temporal, M for maxillary. So that's how you memorize complex things. You just make an acronym, the first letter of each one, and then you memorize it. Okay, so not that important to know the external carotid branches, but I would used to know them because I used to do a lot of cerebral angiograms. I've done about 500 cerebral angiograms, and so I used to have to know those. Nowadays, I don't do the catheter arteriograms anymore, so I don't really care that much about the branches, but once in a while it comes up being useful. Okay, here's the anatomy of the carotid artery in a close-up. So again, here's the external carotid with all the branches, and here is the internal carotid artery. It has no branches, goes right up to the brain. This is just a diagram showing how atherosclerosis forms. Atherosclerosis forms from high-fat diets and high-sodium diets because they cause hypertension. The artery under high pressure hits the median divider between the ECA external carotid artery and the ICA internal carotid artery. It bounces off of there, and there'll be a lot of retrograde flow and chaotic turbulent flow. That confuses the artery. It sheds its antithrombotic glycocalyx, and small clots will form there which enlarge over time. This is where atherosclerosis begins. Atherosclerosis is a blood clot, okay? And that's where it always starts. I've seen like tens of thousands of these, okay? That's where it starts. All right, here is just a diagram of atherosclerosis. So you know that this is the internal carotid in this picture because it's bigger than the external carotid. And like I was saying, it begins right here, bouncing off the median divider, and then it primarily forms here. You'll get a little bit in other locations, but this is the money spot right there. This is just showing the same thing in a little more detail. Internal carotid, it's bigger. External carotid, it's smaller. Primarily forms in the internal carotid right here, opposite the median divider. If a little plaque breaks off, that can embolize distally, means spread distally and cause a stroke. Here's a catheter arteriogram showing the carotid artery. So here is the common carotid artery. Here is the internal carotid artery. It's normally a little bulbous. That's called the carotid bulb. That's normal at the origin of the internal carotid. External carotid just comes up here. You know it's external because you can see all the branches. And this is a normal internal carotid artery. Normal appearance with the bulb. Okay, here it's a severely stenotic. Stenotic is the medical word for narrowed. And you measure the relative diameter of the stenotic segment at the origin of the internal carotid to the normal appearing distal carotid. And that's how you determine the criteria. That's a standardized way to measure it to determine if the patient's likely to benefit from surgery or stenting. Okay. Now here's the same situation, a markedly stenotic internal carotid artery. Here's a catheter arteriogram again. We sometimes call that DSA, digital subtraction arteriogram. Here's an MRA from an MRI machine, magnetic resonance arteriogram, and you can see the same stenosis. Okay, MRI tends to exaggerate the amount of stenosis a little bit. Okay, here's a patient that's undergoing balloon angioplasty of the carotid artery. So you've got the stenosis right here in the internal carotid artery. You're going to get your guide wire up across the stenosis, and then you're going to advance an angioplasty balloon with a stent on top of it. You dilate the balloon, and then the stent flattens the atherosclerotic plaque against the wall, smushes it against the wall. Okay, so that's how you place a stent. That would be an internal carotid artery stent. I do the same thing in the coronary arteries for atherosclerosis. Okay, and that's all I got. So that's a pretty extensive introduction to neck anatomy, and that's how you learn it, one space at a time. You learn the anatomy of the space, and then you learn the common diseases in the space. And you can see how the neck is rather complicated. I can tell you, in my personal experience, usually at most university-type medical centers, only the neuroradiologists will read the necks. The rest of the radiologists, they're going to specialize in something else, like body imaging, chest, abdomen, and pelvis, or musculoskeletal, or something like that. They are not going to want to deal with the neck because it's complicated. The main doctors who specialize in neck anatomy are the ear, nose, and throat doctors. You'll sometimes see an endocrine cancer surgeon operating on a thyroid. Okay, you'll see a plastic surgeon operating on the face, but the ENTs, they are the main ones that do everything in this territory, especially anything to do with head and neck squamous cell cancers, which are quite common, especially in all these smoker drinkers. There's also other types too, HPVs and stuff. Anyways, that's your overview of neck anatomy. I hope you found that helpful.